apologize to Dr. DeVascar because this is too much and too little all in 1 hour. So throughout the talk, you'll hear me making plugs for future Grand Round sessions to really explore this topic in more depth. So let's get started. There are no disclosures for this talk. For our ACGME competencies, I'm very proud to say after taking the time to read over them, we will in one way or another cover all of them during this talk today. So, our objectives: to recognize common case presentations for late preterm infants, to categorize specific late preterm infant health concerns, and then to identify barriers and potentially propose best practices for optimizing their care. Now, a couple of questions just to get everyone warmed up, make sure we're all on the same page. How do you define the late preterm infant? You have A, B, or C as your choice. If we don't have clickers, you can just yell out the answer that you know is the right one. The correct answer is B, 34 and 0/7 to 36 and 6/7 weeks gestational age. So this is a chart that you'll see everywhere as you go through life. And basically, we're going to focus in on this part for this 34 and 0/7 to 36 and 6/7. However, I wanted to bring up another important point. In 2013, ACOG decided to slightly change how they term pregnancy. And a lot of that is related to the differential they were seeing in outcomes. And of course, the most obvious would be respiratory complications, depending on the gestational age that the patients were born. So early term is now referred to as 37 and 0 to 38 and 6. Full term is considered 39 and 0 to 40 and 6. Late term is 41 and 0 to 41 and 6, and then post term is beyond 42. The reason why I'm taking the time to include this definition as well is because for some of the references that I'll be showing you today, they do include, because there'll be a mix of patients that have outcomes that are more in line with a premature, we traditionally think of a premature infant that may be at a gestational age of 37 through 38 and 6. And I'm sure many of you have seen the babies that are born at 37 and 6 and say, I really want to be in the NICU, and you send them to us. So just going back again, for the purpose of this talk, we will be occasionally extending this parameter into the 37 to 38 and occasionally going as low as 32 weeks, mostly because there is some data that tends to group patients from 32 to 36 and 6/7. So in addition to thinking of gestational age, it's also important to consider birth weight, because birth weight, irrespective of gestational age, can be associated with differential in outcomes and adverse impact on the patient. So for low birth weight, it's less than 2.5 kilos. Very low birth weight, or VLBW, is less than 1.5, and then the ELBW is less than 1 kilo. So back in 2003, the March of Dimes came up with this campaign. At that time, the rates of prematurity were literally skyrocketing. And the goals were to raise public awareness and to also decrease the rates of premature birth. In 2004, they created a research initiative, and in 2005, the Institute of Medicine published its first report on preterm birth, which was also partly funded by the March of Dimes. And then in 2005, they initiated the Preemie Act. Anyone in here know what the Preemie Act is? I don't think there's any way for you to guess this unless you knew it. So the Preemie Act, which is actually a public law, prematurity research expansion and education for mothers to deliver infants early. They really tried with that. And they did a pretty good job. But this passed in 2006, and again, it was the idea of reducing these rates of skyrocketing preterm birth, improve care, and reduce the mortality and morbidity associated with it. So in 2005, which is when the Institute of Medicine published its report, they looked at some of the economic impact as well. Does anyone know at that, and there have been no comprehensive follow-up studies since then, so this is the latest data that we have to go on. How much economic cost was associated with preterm birth? A, B, C, or D? Okay, I'm hearing a predominance of C's, weakly whispered, but audible. So the actual cost was $26 billion. Now, one of the things that I'll do to the residents when they're on with me in the NICU, I'll be like, just do the math in your head, just try, without the calculator. and 17 billion, which is roughly 2/3, solely on medical care. So not even considering what happens to the patients after their discharge, but solely on medical care. And that was about 10 years ago. Now, you're going to say, Valencia, you're a neonatologist, and you guys are resuscitating those 22 and 23 and 24 weekers, and they're the ones eating up all the cost with that 26 billion. I'm going to give you an alternative perspective to that argument. When you look at the percent of preterm births, and this has not changed despite what efforts we've made to decrease the overall incidence of prematurity, 70 to 75%, depending on the data you look at, are late preterm infants. In addition to that, remember I mentioned that we might talk somewhat about this 32 to 34 week range? That's another 12 to 15%. So when you look at the sum totality, you're talking about 85% of the burden of prematurity is really in this late preterm infant stage. And there'll be additional data that we'll see as we go along that shows how much healthcare costs actually goes into taking care of those patients. So let's start or continue with some case presentations. Then hopefully this will ring true with many of our community pediatricians that are in the audience today. So case 1. 36 and 4/7 week fraternal twins delivered by C-section because of IUGR status of twin B. For their birth weights, A was 2450, B was 2260. So in addition to their prematurity status, they both meet the criteria for low birth weight. They were admitted to the nursery based on the parameters set for admission to nursery on their birth weight. There was an AccuCheck done at 2 hours of life on twin B because of the IUGR status, and it was 39. They attempted breastfeeding, and it was described as fair. A repeat AccuCheck was done, and it was at 38, and the patient was supplemented with formula. After feeding, the postprandial was 40. So they continued with formula supplementation every 2 to 3 hours. AccuChecks remained in the 38 to 42 range, and those were confirmed with the serum glucose. And the patient was eventually admitted to the NICU at 12 hours of life and had approximately a week-long hospitalization. I'm not going to give you a lot of resolution at this point because we have a lot more to cover, and I hope you'll come back to this case and kind of see how it plays into what we know about preterm infants. But let's go to our second case. These are also twins. They're a little bit younger, 34 and 2/7 week. They were actually delivered vaginally because mom had maternal preeclampsia. Now, these little guys went straight to the NICU. They didn't even get a chance to go to the nursery. And by our standards as the neonatologists, we didn't intubate them. They didn't get sepsis. They didn't develop NEC. They might have had a little bit of oxygen for a day or two. They're easily forgettable in our world in terms of the amount of trauma they cause to us. And I say that obviously jokingly because we adore and love our patients, but there are those patients, right, that stay with you a little more than others. To back up this claim of uneventful, they were home within less than 2 weeks. So they were discharged by 36 weeks corrected gestational age, and then they were seen at the NICU high-risk infant follow-up at 1 year. Now, are you guys pretty clear on how patients end up being referred to high-risk infant follow-up? So I thought a couple people might shake their head, and I have something that's really busy. Everybody take a deep breath. This is the part of the presentation that you appreciate the fact that it's recorded and you can come back to it. But there are a couple of important things I want to point out. So one, patients can actually come to high risk even if they weren't in the NICU. So let's say you have a 1-week-old that gets admitted to the PICU here, but may have been born premature or comes in with sepsis or something like that. Technically, that is a CCS qualification, and you can potentially do a referral to high-risk infant follow-up. So the next thing is, let's say that you have someone who's more than 1,500 grams and greater than 32 weeks, but went to the NICU and ended up with some complications. The patient that was on ECMO, we definitely want to see them again. But even as you go down into some additional considerations, there are things such as documented sepsis, high bilirubin levels, cardiovascular instability, so the patient that may have been on dopamine or something to that effect, and necrotizing enterocolitis. In addition to that, it's important to remember that for high-risk infant follow-up, you can have 3 visits, but it's only up until 3 years of age. So you have somewhat of a short window, but you definitely have opportunities where there are patients that may not quote-unquote traditionally meet the criteria you think of as the 24-weeker that was in the NICU, that at least in the state of California qualifies for referral. But let's get back to our case, because I thought that was just a quick little tangent that would be helpful to take. Made it to the high-risk infant follow-up because that patient actually had apnea and had been treated with caffeine for a brief amount of time during the hospital stay, even though it was very short. And that's one of the things that's included as a potential for referral. At that time, occupational therapy evaluated the patient and said, we have some concerns for sensory integration. Okay, how many people in here have a good feel of concerns with sensory integration and what that means for a 12-month-old? Wow, you guys are getting quieter and quieter as this talk goes along. Okay, so let's do one more detour. So, abnormal sensory integration. This is a generalized list. Obviously, we won't see all those things in a 12-month-old, but some ones that we'll pick up on. Delays in speech, language, or motor skills, unusually high or low activity level, easily distracted, oversensitivity or underreactivity to touch, movement, sights, or sounds. Then as patients get older, delays in academic achievement, inability to self-soothe, and impulsivity. Now, some of you may be going, as pediatricians, we think about a lot of those things when we're taking care of patients on the autism spectrum disorder. And that's not something that we may want to put a pin in to come back to a little bit later. So again, this was something that came up with these twins who had had this relatively benign, NICU course and were pretty good size and otherwise doing well. Unfortunately, they were lost to follow-up and did not return to the high-risk infant follow-up clinic. And they presented to a new pediatrician at 3 years of age. So how many of you are looking forward to seeing, brand new patient, vague history of NICU stay, maybe an issue, we're not sure. And at this time, mother is now clearly having complaints of impulse control issues with her twins and witnessing repetitive stereotype behaviors. So I'll leave you with that dilemma because this is the pediatrician's predicament, hence the title of our talk. And for our last case, before we move into those unique health concerns we want to discuss, you guys are going to say, I've given you 34-week twins, I've given you 36-week twins. I mean, we know multiples have additional issues too. How is this necessarily specifically about late preterm infants? Well, how about a 35 and 6/7 weeker? Little preterm labor, admitted to the nursery for routine care, discharged at 31 hours of life, everything looked good, fed well, no issues. Was exclusively breastfeeding, and weight was down 8% at time of discharge, so less than the 10% that we traditionally think about. Presented to the pediatrician exactly 24 hours later. They were like, you must follow up within 24 hours. They were there in the pediatrician's office. Still required readmission for hyperbilirubinemia, poor feeding, and hydration. I'm pretty sure if I had a show of hands for how many people have had that patient, almost everyone's hands in here would go up. And I see a lot of head nodding in the affirmative. Well, the thing is about each of these cases, they all clearly illustrate the type of scenarios that are encountered by pediatricians as they're required and expected to take care of these patients once they leave the nursery and or leave the NICU. So let's go into some of the specific health concerns that we need to consider for these patients that are maybe a little too well for a NICU stay, but not exactly a well baby. So what we know for sure is that these patients are going to get more medical interventions. They're going to have typically longer hospital stays. They frequently will require NICU admission, as we saw in our first case scenario. There is absolutely an associated higher cost of care, but some of the things that I hope I'll be able to touch on and illustrate for you much better today is the definite association with abnormal neurodevelopmental outcomes that maybe we have not always appreciated or focused on in the past versus, let's say, the 23-weeker, 24-weeker, or even 28-weeker. And very clearly, there are increased mortality rates for a variety of different reasons. So just to talk very briefly about mortality, because I wouldn't have a lot to talk about if that was all we had to say today. When you look at major causes of infant mortality, so not neonatal, but infant mortality in the first year of life, prematurity is in the top 2. So clearly this is having an impact. And again, as I showed you before, this is not just the 23 or 24 weeker who typically may, if they survive, are going to survive versus the ones that may lose their life within the first 28 days. Okay, if you decide to fall asleep, if you don't remember anything else that we talk about today, remember this slide. So this is our cheat sheet slide for you. When we talk about our health concerns, we want to break it down by immediate postnatal, first week of life, first month, early infancy, and as I mentioned, spend a little bit of time thinking about the neurodevelopmental. So from a postnatal perspective, the things that we usually are seeing, respiratory distress, RDS and TTN, temperature instability, hypoglycemia, and feeding difficulties. Within the first week, we'll add to that neonatal jaundice, apnea, sepsis. Within the first month, particularly as we start looking at reasons for readmission, again, we're seeing more with poor feeding and dehydration. And then as we get into early infancy, we consider the increased risk for SIDS. And then for neurodevelopmental, we've touched on it just a little bit. We'll talk about it a little bit more. Learning difficulty and school failure, as well as behavioral problems. And again, we're already kind of thinking back to some of the case scenarios that I've presented to you already. So this paper was published by a group down in San Diego, and it's probably the paper that really helped us, not that it was the first, but a paper that really kind of put it together for us, the different complications that we should consider and think about with our late preterm infants. One of the common things that we first consider is their respiratory distress. And a term infant, maybe a little bit of TTN or occasionally pneumonia, it's only about 4%. But as soon as you get into that late preterm population, the incidence of respiratory distress of any type is going to jump all the way up to 28% of that patient population. Now, part of that is because just when you're born premature, you interrupt this transition from the very premature lung to the full alveolarization, which takes place between 36 weeks. And this slide says 3 years. They're actually moving that up to anywhere from 8 to 10 years. You're continuing to make new alveoli. The other thing that you have to remember is that in addition to just overall development of structure and alveolarization, there's just size and volume. So at 35, 34 weeks, the lung size is only half of what it's supposed to be for a full-term infant. One of the phrases I'll use is that, they're just not done cooking yet. There's still a little bit more that needs to happen. And it's still a significant amount if you think of the lung volume size doubling over those last 4 or 5 weeks of gestation. So that leads us into a somewhat hot off the press New England Journal of Medicine article by the NICHD network. And it was primary author by Dr. Jane, who's a neonatologist in Atlanta at Emory. So I got to throw my Emory connection in there a little bit. But basically what they wanted to see was, we know that betamethasone works great for patients that are premature and have RDS. Is there any reason to think that giving betamethasone to mothers could potentially make an impact on respiratory outcomes in that patient population? So that was their primary outcome. It involved 17 centers, and they looked at almost 3,000 mothers who had singleton pregnancies between 34 and 0 and actually 36 and 5/7 weeks. And what they did was they gave betamethasone 12 milligrams IM every 12 hours, just 2 doses, with the idea that mothers were not anticipated to deliver within the next 24 hours. And then they looked at whether or not they developed significant respiratory distress that required intervention in the first 72 hours of life. So when you look at their primary respiratory outcomes, what they saw was a significant decrease in the patient population, and this is N of 1,427. So for neonatology, we almost never get studies that have this large of a sample size. So this was pretty impressive. And they saw a significant improvement in that group. When they looked at some other things, they looked at their composite of RDS, TTN, and apnea. So basically across the board, they did see improvement. But if you necessarily look at things like that you wouldn't expect, like ECMO, I mean, there was no incidence of that or things like that. So they absolutely achieved their primary outcome. What they noted is they would have to treat 35 mothers in order to, get to this type of outcome. So a lot of people had questions about that. But then there were also questions about some of their secondary outcomes. So when you looked at their secondary outcomes, a couple of things that stood out. One, hypoglycemia was significantly increased in the patient population that received betamethasone. Well, we just said hypoglycemia is associated with late preterm infants early on, so are you doing something potentially to make it worse? Interestingly enough, when you look at the amount of time that they spent in the hospital, even though maybe more of these babies had hypoglycemia, they still had overall shorter duration of hospital stays, unlike the patient that I presented to you in the first scenario who was admitted to the NICU and actually stayed in the NICU approximately a week. Now, they're still sorting through what all those things mean, and we'll continue to have some questions and debate about it. The other thing that's important to know is that only 60% of the patients received 2 doses of betamethasone. So that also may potentially factor in, and maybe just 1 dose might be adequate to show effect. And then if you have questions about the 2 deaths that occurred, one was due to overwhelming sepsis and the other was due to an arrhythmia. There's no reason with the numbers they have to expect that was related to the use of betamethasone. But again, when you're doing something like this and really trying to get in perspective, you really have to see it over large populations over time. But all in all, this seems to be something to consider. You might ask, why does this work? Well, have you ever had a neonatologist that couldn't tell you if your patient had RDS or TTN? So there's this in-between world that late preterm infants live in where they don't have a true surfactant deficiency, but, and some of this is related to the excellent work that Dr. Jane has done, they have a true inability to clear their fetal lung fluid. And so they don't have the normal extra-unit adaptive response, and that contributes to the respiratory distress you see. So when a neonatologist tells you that, they're actually telling the truth. It's a little bit of RDS and it's a little bit of TTN. That doesn't go so well with billing, but physiologically that's somewhat what's happening. So, I mentioned that hypoglycemia was a concern, and then I came across this slide because I was trying to find a talk about is 60 the new 40 for hypoglycemia newborns. Now, as a neonatologist, I've had my 60-year-old mother that I did the consult for the delivery of her child, and so when I saw this picture, I immediately thought she was pregnant. You guys can decide what you think, but the most important thing is we want to talk about how do we really address hypoglycemia in the newborn period. And just like this picture is controversial, the entire next part of this discussion is controversial. So this is my first plug for we should have a talk about neonatal hypoglycemia. That being said, in the time that we have today, there are multiple controversies and absolute disagreements about the definition of neonatal hypoglycemia and whether or not it has an adverse impact on neurodevelopmental outcomes. Next up, and I'm not sure if I saw any of our endocrinologists in the audience, the American Academy of Pediatrics and the Pediatric Endocrine Society have very different guidelines and recommendations in terms of approaching neonatal hypoglycemia. The AAP came out with their guidelines in 2011, the PES had their guidelines in 2015. One thing, though, that the AAP has acknowledged and does recognize in terms of the PES guidelines, their guidelines are really intended only for the first 24 hours of life. So when someone calls you at 48 hours and says a patient has a glucose of 45, that is absolutely abnormal. And I'm unfortunately, sad to say there are so many times where I have gotten that phone call or the nurse wants to know why I want to follow up on the sugar or do something about it. So please, please, please remember the AAP guidelines are solely intended for the first 24 hours of life. That being said, one of the things that they can agree on with the PES is that the PES is trying to stress that we don't miss this scenario of persistent hypoglycemia because of the concerns that the brain is dependent on glucose for energy, for fuel, and prolonged hypoglycemia is a concern. Obviously, if the patient's symptomatic, and by symptomatic, we typically think seizing, but symptomatic does not have to wait until the patient is seizing from hypoglycemia. We know that's problematic. So let's take a look at the 2011 AAP guidelines. Both guidelines stress that you don't just go around poking babies and checking their glucose, especially a healthy term baby. A healthy term baby has an appropriate physiologic decrease in glucose after they're born. They tolerate it fairly well because of their relatively high number of ketones. The idea is you need to know who are the patients that I should screen. The AAP has said any late preterm or term small for gestational age infant should be screened. Any IDM or LGA infant should be screened. I'm here today talking about late preterm infants in general, not just the SGA ones. So this is where I'm going to say I somewhat disagree with the AAP guidelines, and I think based on the case scenarios I've presented, you'll see why. But let's go with what they have so far. Again, if the patient's symptomatic, it doesn't matter what their glucose is. If it's low, you should automatically treat. The question becomes when they're asymptomatic. So from birth to the first 4 hours, you're expected to initiate feeds within an hour. If you're in a baby-friendly hospital such as UCLA, that falls in line with our guidelines to establish breastfeeding, and there should be no controversy there. There's no rush after the baby's born, of course, unless they're seizing, to poke them right away, even if they're a potentially at-risk patient. You want to give them that hour, allow them to feed, and then follow up appropriately. If the initial screen is low, you feed and recheck in an hour. If it remains low, you obviously move up in terms of how you intervene to address the hypoglycemia. Now, when you go to 4 to 24 hours of life, you should be feeding frequently, and if it's less than 35, this is when you follow up as well. Now here, the target glucose should be greater than 45 prior to routine feeds. If you think about the patient that I presented to you earlier, that patient kind of hovered around 40, but never quite got to 45. And what was most concerning is that even from a postprandial AccuCheck, it was only 40. So symptoms of hypoglycemia. These are the things that we talk about: irritability, tremors, jitteriness, an exaggerated marrow, a high-pitched cry, seizures, which are always worrisome, lethargy. But here's another one: poor feeding. Now, how many of you know that late preterm infants have poor feeding? So again, if you think about all the multiple things that are going against them, you can understand why I might have pause that just being a late preterm infant is not considered as a part of this screen. Let's contrast this to the recommendations from PES, and their perspective again is making sure that we don't miss those patients with persistent hypoglycemia. Now, the big thing to consider is the one chart they have here, which is recognizing other infants that are considered high risk. This is a little small, but perinatal stress, and I think particularly for those of us who have the sick babies that come to the NICU, we do see patients that have issues with glucose homeostasis, and we a lot of times have to intervene. But again, those that have birth asphyxia, but even if there's a C-section for fetal distress, that is presumed perinatal stress that puts that patient at risk, even if they quote unquote seem asymptomatic or look fine. Maternal preeclampsia, which is another one of the case scenarios I presented to you, and then IUGR, which was initially in our first case presentation. The other obvious one that they list here is prematurity or post-mature delivery, hence my argument to the perhaps adjustment to the AAP guidelines. And then lastly, what I've already touched on is that by 48 hours of life, you should be approaching normal glucose levels similar to what you see in adults. Now, the PES is pushing for glucoses greater than 70. I don't think pediatricians are ready to go all the way to 70, but for sure, if you have a patient that's 2 or 3 days old that still has a glucose of 50, that is never normal. And it needs to be looked at further and potentially investigated and worked up. But the details of that, unfortunately, is outside of the scope of what we can discuss today. So hypoglycemia, late preterm infants, I mentioned they have poor feeding. So their poor feeding is related to their immature suck and swallow. They have less awake alert periods. They have decreased stamina. That also means that they aren't able to create the suction and extraction of milk to really stimulate mom's supply. So in addition to them having poor feeding, they're not doing enough to really help mom have a robust milk letdown, which then feeds into a cycle that just exacerbates the problems that exist. So that will, of course, make you have worsening hypoglycemia, jaundice, dehydration, and poor weight gain. So then you become the patient that we saw in our last scenario that was readmitted with dehydration and jaundice. So you get into the higher readmission rates, and then, of course, you've completely thwarted your efforts to have strong maternal-infant bonding. So with that, jaundice we recognize is a huge issue in this patient population and a big part of what we see with our readmissions. So back in 2013, Dr. Young from Utah, Intermountain, published this paper looking at early readmission of newborns from the well baby nursery. So these are patients that never saw a neonatologist, never saw the NICU. And what they found was when they looked at causes for readmission, it was about 18 per 1,000 patients. Feeding problems and jaundice were 1 and 2 and made up the bulk of patients that they had readmitted. Then they said, let's look at this based on gestational age. And so here, late preterm infants by far had rates that were closer to 35 per 1,000 in terms of readmission. But remember this term that I told you about, the early term infant, also had higher rates of readmission and much more than what you initially saw with just the 18 per 1,000. So again, if these patients aren't being recognized and screened and picked up, they're ending up back in the hospital with complications and issues. One of the things we worry about is, are we missing sick babies? Are we not intervening when we need to intervene? How vulnerable are they to some of these things like hypoglycemia and severe hyperbilirubinemia? And in addition to that, the brain is still undergoing a tremendous amount of development. So similar to the lungs, that it's only at 50% volume at 34 to 35 weeks. At 34 to 35 weeks, the brain is only 2/3 the size and maturity of a full newborn. So really, those 4 to 6 weeks make that much of a difference in the development of a baby. And they may look fine on the outside, but again, there are still a lot of things cooking. So I don't know if any of you have been to New Orleans or are familiar with like gumbo, which is one of their famous dishes. So there's a whole roux that you have to make, which is really challenging. There's getting everything in the pot, but you could do all of that right. But if you take it off the pot too early, you will have a ruined pot of gumbo that is not edible. So we kind of can shift that into the idea of when I say that our patients are still cooking. There's everything they need, but it's just not where it needs to be yet. And as the practitioners, we have to be mindful of that and look for maybe things that are potentially subtle, but have an immediate impact and a long-term impact, which we'll discuss next. So just to explain where March of Dimes got this comes from a paper by Kinney et al., the Near Preterm Human Brain and Risk for PVL, and that was published back in 2006, where they were able to kind of plot brain growth. Another diagram from this paper that I really like is just comparing what you see in the near-term infant versus the tiny little, incompatible with life 20-weeker versus the nice maturity and development you've seen, again, within that 5-week span. I mean, just visually inspecting, you can tell the difference between the gyri and sulcation formation. So what are some other neurodevelopmental things we need to consider? Well, there are 3 different assessments that were done by Spittle et al. Back just earlier this year. And one of the things that I wasn't aware of until I came across this paper was Prechtel's General Movement Assessment. And this is something that they do out of Austria. And they actually videotape patients for 30 minutes to an hour, because what they find is that you can just tell by movements who might be at higher risk for developing cerebral palsy. And it's not about a change in the frequency, but it's a change in the type of stereotypical patterns that you see. And it is interesting in that it has a very high, once you're trained properly in technique, reliability between like different professionals that perform the exam. Now, one of the things, as I mentioned, when you look at who's likely to have a normal GMA, most full-term healthy newborns will. But look how precipitously that drops off as you get into the late preterm infants. And that starts to help you suspect that they are at higher risk for abnormal neurodevelopmental outcomes. But that's just one paper. And it's using something that we don't classically use here in the United States. Well, how about looking at things besides our traditional, motor function or how they perform on a Bailey? What about asking parents, how hard is it to feed your kid? So most people know what it's like to have a toddler that goes through their feeding independent food phase, but on a much more exaggerated basis. Patients that are born premature have much more issues with feeding, oral motor problems, being a picky eater. Of course, these findings are mediated by potentially other things that have contributed to neurodevelopment, but the important thing to remember is that it's another stressor on this family, and it's another potential risk for poor outcome just because it becomes an issue trying to figure out how to get proper nutrition and how to do appropriate feeding. So it's very multifactorial and layered. It's also a place where you start to see considerable health disparities pop up in this population. And we'll get into that a little bit more. So this is from JPEDS, August 2013. So looking at moderately preterm children in a low socioeconomic status, they had more issues with developmental delay. Now, this wasn't a study that was done in LA or New York or Detroit or Atlanta or Miami. This was actually a study that was done in Finland, which is one of our places that we look at in terms of like social health care and things of that nature. So they definitely saw in those families that had lower socioeconomic status, patients did worse based on their gestational age. The one thing that they did not show the data on is that even for patients with a higher socioeconomic status, if their child was born premature, they still did worse from a neurodevelopmental outcome as compared to patients that were born at term status to families with similar higher socioeconomic status. So the thought process was, and they did a variety of logistic regression models, is that gestational age, even though there are other variables that could be confounding, still showed up as an independent variable for worse outcomes. Now, I'm a neonatologist. I never have to see the kids that are going to high school or junior high or middle school, but they still show up again in the pediatrician's office. And so you're saying, Valencia, you showed me a lot of data about, newborns and infants. What about my older kids that are showing up in my office? So there particularly are, studies that have looked at risk ratios for poor outcomes and have seen higher risk even for high school, like not being able to graduate. So those studies are out there and they exist as well. This is just a brief snapshot of some of the studies that are available. But again, it's enough to make us pause and consider, there's definitely a plan in place for that 28-weeker. And the full-term baby, if they present in your office and something doesn't seem right, you're going to be pretty aggressive. But just remembering, late preterm status alone is enough to put that patient at risk for some pretty significant adverse neurodevelopmental outcomes. And this crosses the spectrum, including psychiatric disorders and other things, again, that are outside the scope of this conversation. So when you put it all together, you have to think there are multiple mechanisms that contribute to these behavior outcomes. So there's what happened during pregnancy. There's if there's any brain injury. There's the effect of nutrition, and I touched on that a little bit, even in the older patient that may have feeding difficulties outside of the neonatal period. But then we can't forget the social determinants of health, such as the social economic status and barriers to healthcare intervention. There still are patients, as I mentioned before, for one reason or another, get lost to follow-up. So that leads us into how do we think about these barriers and what can we do differently? How can we make an impact and change things for the better? Well, first, let's figure out what we're trying to change. So the U.S. Healthy People 2020 goal, so 4 years from now, we want to get the preterm birth rate down to 11.4% across the country. March of Dimes, their goal is actually 9.6%, so they're a little bit more aggressive. And so you guys are probably thinking, hey, that seems reasonable. We had a high of anywhere as 12 to 13% for preterm birth. There are multiple factors that contribute to it, but again, that late preterm population makes up anywhere from 75 to 85%. I'm just gonna give you one quick little caveat. In 2010, the goal was 7.6%. So someone figured out this really isn't going to go as easily as we thought or as well as we thought. So just to give you a little bit of perspective, but not to depress you, because I actually, have some good news about California. When you look at the 2014 report card, California is in purple. You get an A. So California has actually already met that 9.6% goal set by the March of Dimes. So we're doing well. We're getting our preterm birth rates down. But it's not that clean. When you look at breaking it down by ethnicity and race, we still see a lot of disparities that are above for African American, Native American, and particularly Latino populations. So even within the state of California, there are definitely places where we have room for improvement, and we can really make an impact, which will make an impact across our families, across our populations, and of course, when we look at our economic costs as well. So some of the barriers that we need to think about as we try to charge forward with this idea of making a difference, making sure that we actually know the gestational age. So you can dust off your, handy Ballard exam, or if you're at Santa Monica like me and you have a lot of IVF, you can ask the perinatologist when it happened. But when the patient's in the hospital, we have to think about systems outside of just us and our own practice. Our nurses actually have a huge impact on how well these patients are cared for and how quickly issues may be picked up. But if you have a nurse who may be taking care of 3 or 4 mother babies, and then you throw in a 35-weeker that's not feeding well, it's a little bit easier to just kind of check off the boxes and maybe not pick up on some of those subtle cues or issues. It's really helpful to ensure that there's adequate breastfeeding. And I've already mentioned that these little guys can look like they're doing everything right, but what they're actually accomplishing is typically not what you think it is. So having both occupational lactation support, and by lactation support, you want specialized lactation that understands how late preterm infants feed quite differently than the healthy term baby. There are distinctions, and it's important that the lactation doesn't approach the late preterm baby with the same techniques and methods they might use in a term newborn. Oftentimes that will be very unsuccessful and not fruitful. The other big thing we have to recognize is parents need to know, hey, you've got a little one that's premature, and we're going to look at your baby a little bit differently, especially in that first few days or weeks of life. And then we have to kind of rethink what we consider early discharge for these patients. Now, this is an actual statement from the AAP. Timing of discharge is individualized and based on feeding competency, thermoregulation, absence of medical illness, and social risk factors. Late preterm infants usually are not expected to meet the necessary competencies for discharge before 48 hours after birth. Now, I can tell you that, and I can tell you that the AAP said it, and then you can be here in the nursery and you can send me an email, Dr. Walker, you're the director, and they're telling me I gotta kick all these babies out. That being said, I would refer to what my own boss, Dr. DeVascar, told me. Sometimes you have to stand up for the babies. And that's a part of thinking about systems change and thinking just outside of what test I need to order next. But you have, the support, the guidelines, and the policy to back you up. Now, what are some more practical things we can do? You're like, I'm not going to go change the system after I leave Grand Rounds today, and that's fine. We can talk about that a little more when we do our next Grand Rounds. But You can get your initial AccuChecks to make sure you're not missing significant hypoglycemia and recognize that a lot of times these patients are a part of that high-risk population that may not immediately show up when you think about the AAP screening guidelines. You should probably intervene if that patient has lost more than 6%, particularly in the first 24 to 36 hours. I hopefully see Dr. Lin shaking his head yes to that one. The other thing that's absolutely critical is making sure that breastfeeding is working. Not maybe working, not it could work, but that you've established reliable breastfeeding and recognizing in that late preterm infant, it may take a while. And of course, you have to screen for hyperbilirubinemia. Lastly, I've mentioned some of the disparities that can exist, but it's important to think about other things that may not typically come up in your conversations when it comes to postpartum depression or anxiety. I know that it's varied across different practices if it's done in the office or if it's done before the mothers leave home, but please just keep that in mind as well. So what should our discharge criteria be? More than 48 hours of life, stable vital signs, effective feeding, adequate milk supply, a stable weight status, a bilirubin assessment and or treatment if it's indicated. And then we actually do car seat screening. I'm not sure if he's actually sitting in there as well as he could be, and definitely looks a little jaundiced to me, so I hope that got checked. But these are things we consider. The other thing that's really critical is establishing an interprofessional team. I mentioned how important the OT and lactation can be to assist you. And then just putting up visual cues as reminders. Hey, when I walk in this room, this is a late preterm infant. You know, I've got a couple extra things I need to discuss with this family. And one of the things that we're starting to do at Santa Monica is apply some QI initiatives to assess our management, and then making sure if you aren't going to be the follow-up PMD, that you're really communicating to the parents exactly what to look for, why they're following up, and what issues or concerns that may happen. And then remembering, you may not see the neurodevelopmental issues right away, but you do have backup and support to consider if things come up that are concerned, even if it seems maybe minor in terms of this vague sensory integration issues that aren't as specific in the older child as in the younger child. Now, we're kind of playing around with this project, and we call it A Little Time for a Little You at Santa Monica, and we're starting to transition into Regan. So we're educating our staff. We're instituting some specific treatment guidelines, and we're working now on updating the discharge instructions. We just updated the regular newborn, so we're moving on to late preterm. And our primary goal was to make sure no late preterm infants got readmitted within the first 30 days of life. Because we felt if most of this was related to dehydration and jaundice, these were things that we could address. And of course, promote positive long-term outcomes. So these are all of our collaborators. And what's interesting is that we looked at data just from a short period of time. Only one was discharged at less than 24 hours of life, but one of the things that really worried us is that there were patients that were being discharged without bilirubin evaluations. And this was happening both for full term and for late preterm infants. So we found some things that we could address even outside of the late preterm issue. Now, looking at the statistics we found, there were more patients readmitted that had been born at Ronald Reagan, but overall our rates weren't unreasonable. So we felt getting to 0 wasn't an unrealistic goal. Now, here's the thing. We've looked at our progress, even though we haven't put everything formally in place, and we actually haven't had readmissions at Santa Monica. So it kind of blew the QI perspective part of this out the water for me. And we're still working on getting our consensus with lactation. We're still building our interprofessional collaboration and creating our materials. The thing that did come up, and I thought I had included on the slide, was we found out there are actually more term babies being readmitted with hyperbilies. So we were like, that's another project that's on the horizon. So that's the end of my talk for today. We do have time for some questions. I want to thank some of the people I've been able to work with across the country that have given me excellent advice and guidance, and of course the main team of people I have here working with me as well. Thank you.